In this session, we are looking at a prostate and bladder, here, taken from a 57-year-old man who was admitted to hospital in a coma. The patient had a previous history of prostate enlargement for 4.5 years and was in a coma for 3 days prior to admission. Retention of urine with a grossly enlarged prostate, that we can see here, was found upon examination. With a blood urea concentration of 50 millimoles per litre, this patient consequently died without recovering consciousness. Macroscopically, we can clearly see gross enlargement of the entire prostate gland, this region here, and in particular, the middle lobe of the prostate gland. We can also see that the mucosa of the bladder, within this region here, is severely congested, and the muscular coat of the bladder wall, this area outlined here, is severely hypertrophied. And this gives rise to the prominence of severe trabeculation of the mucosal surface of the bladder throughout this region here. The posterior lobe of the prostate gland, this area here, is also projecting into the bladder lumen, contributing to the obstruction of the urethra, which was here. Whilst this tumour is benign, at the histological level, we would expect to see a significant degree of hyperplasia, or cellular proliferation, and this would be mainly affecting the fibromuscular tissue, or stroma, of the prostate gland itself. We may also see papillary infolding and cystic dilation.
And now we'll describe the microscopic changes in the development of benign prostatic hyperplasia, also known as BPH or nodular hyperplasia. Subsequent to a urologist taking an ultrasound-guided fine needle biopsy, tissue sections are stained, typically with hematoxylin and eosin, to show key characteristic architecture of the developing BPH. Characteristics include cystic dilation, where glandular-like structures have lost the epithelial cell lining and no longer make secretory material that forms part of the ejaculate. These cysts tend to grow and accumulate in size, adding to the wet weight of the tissue. In addition, we see significant epithelial cell proliferation or hyperplasia, leading to significant papillary infolds of the epithelial lining of glands. We also typically see fibromuscular proliferation, where the muscular stroma, which is the layers of muscle cells between gland-like structures, also starts to proliferate. So there is an increase in size of the overall organ, that is the prostate, due to a combination of cystic dilation, papillary infolds, which lead to incomplete production of secretory material into the gland-like structures, as well as fibromuscular proliferation.